And the low risk, of course, there are cases where I have seen few cases where no habits at all. At this point, I would like to tell everybody, it is not necessary that patient should have a habit. Very few cases come with a trauma caused by sharp tooth, as told. It can be a denture, and mostly I have seen some cases in Cancer Institute where the first premolar, lower first premolar or second premolar is placed very much lingually away from the occlusion. This lingually placed tooth causes ulceration at the lateral border of the tongue where there is no habit, and I have seen young patients like 20-year-old girl with a cancer of the region. This was missed by the dentist. If she would have had it removed, probably this would not have caused the problem. So as a dentist, our role is to see, examine the patient properly if there is any sharp margin or anything, even a simple extraction. When you do lower tooth extraction, I would advise you to run your finger around the socket, see that there are any bony margins will be left. That bony margin can first roam onto the lateral border of the tongue. Patient may come again and again and you would have missed it. Unless you are going to feel with your finger the margin which you have to trim it with your bony neurologist. So the role of the dentist plays very important in oral diagnosis of oral cancer. Only we have the chance to diagnose. All other cancers which occur in the body, you don't have the picture. Whereas this you are able to see is, you don't need a microscope. You can macroscopically see the lesion and advise the patient. So the role of dentist is very, very important in cancer. And even after post-treatment, normally I don't know how many of you have heard about the obturators which you do. Obturators are very necessary in the role of the dentist. That is a technique which is, it is you have to learn about. Taking an impression for an obturator itself is difficult. So, as sir had asked, role of a dentist is very important, not only in diagnosis, even post-operative. Thank you.
Thank you, sir. Your words of wisdom for being a budding dentist will definitely help. Now, there is a perspective of a dentist towards this, and there is an oncologist perspective towards what we would expect or a dentist to know so that they can actually serve better. So this is what we feel, that prior to treatment, as sir rightly summarized, prevention and counseling with regards to tobacco and alcohol, screening and detection is very imperative. That if you have a patient coming to you or scaling and you find a sharp tooth, spend some time with the patient. Just smoothing that tooth will really go a long way. These are small things, but they'll all make a big difference. Document all your findings. If you find a leukoplexic patch of 1 centimeter and 3 or 6 months later they come for another procedure and you find that the leukoplexic patch is slightly increasing, then your antenna for suspicion should go up. So it's very important that we document our findings. Now everything is picture based. I know a lot of dentists nowadays have their own patients with all pictures of tooth and the oral cavity. It makes a huge comparison advantage that you will have compared to any other clinician. An oncologist will see this patient after the patient develops a malignancy, but you will be seeing them every consult when they come for a dental extraction or a scaling or whatever. So it's imperative that you document the findings and have a low threshold for suspicious lesions. Anything patch which is not healing or a patch which is progressing, despite your attending to a sharp tooth, it's important that we have a suspicion in these patients, consider a biopsy or maybe a referral in the situations. As sir rightly said, in older people, especially females, one of the most important causes in elderly patients developing cancer is malfitting dentures. Dentures and operators, if they are not fitting properly, the constant trauma is a common cause for squamous cell cancers. Do not think that you can watch and wait. Wait for 6 months is not an option. Waiting for 6 months is not an option when you have a suspicion of a malignancy. Now, what do we do with this? Once the treatment is being started, our radiation oncologist will tell us what they do before treatment, pre-treatment, what do you expect from a dental cell?
Before treatment, we want a complete dental checkup and clearance with them. Any rampant caries, any loose tooth, any underdeveloped caries, all we want to be clear. Because once we start treatment, we can't do any dental treatment for at least for next 6 months. And moreover, before starting treatment, any extraction done in the treatment area, we require at least 10 days to 14 days to heal. without healing, if you start treatment, the patient will have a lot of difficulties. And, and we want dentist to be very good because post-treatment, most of the patient will land in xerostomia because of thyroid gland problem or something. And again, these xerostomia will lead to a lot of dental problem. So we want you to learn and see how to manage xerostomia which occurs post-treatment. And more important, you should have a thorough knowledge of OR. So OR is the most burning problem in most of the oral cavity cancer post-treatment where the patient suffers a lot. And long term, as I told very clearly, look for any suspicious unhealthy area in the oral cavity whenever you see a patient, whether it's a cancer or not cancer, whenever a patient comes to for any reason, try to have a thorough checkup. And like what I told, the operator post-treatment, that also should learn, and you only the fitting obstacle at least 3 months post-treatment, allow the area to heal properly, then take a measurement. Taking measurement immediately after post-treatment may not fit after 2 to 3 months. So wait for the healing, you proper healing time, then make appropriate processes. And also, whenever you need to take care of dental treatment, like patient will have sensitive, patient may have difficulty in chewing. So where you can have a fluid toothpaste to help them.
One man has been sitting silent in the panel. We need to involve him. Sir, bisphosphonates, whenever you give bisphosphonates, right? I know this is not the case for an oral cancer, but bisphosphonates, whenever you start giving bisphosphonates, you always ask a dental opinion. What is it you ask for and why is it so important?
Good morning. It was a great event. Good morning. I enjoyed a lot of interactions from your side, and then it was a great MC, and everyone was clapping, and we also joined the fun. And me and Harish, we are also part of a dentist association, because both of our wives are dentists. So, okay, thank you. So, thanks for involving us. So, bisphosphonates means that it's something which we give for osteoporosis. So, any post-menopausal payment and or in cancer, whenever there is a skeletal related events, we try to give bisphosphonates to improve the bone strengthening. The problem with bisphosphonates is that it can cause osteonecrosis of the joint, so ONJ. So irrespective of whether the bisphosphonate is going to be zoledronic acid or hyaluronic acid or chloronic, or even the latest RANKL inhibitor, denosumab, all can end up with the ONJ. So before starting these bisphosphonates, we send to the dentist to see whether the oral hygiene is good, whether the gum involvement is there or not. Because this is where when we give, the patient goes in for some infection. And also we tell the patient not to have any tooth extraction done at least 3 months prior and post to the bisphosphonates. So if we want to give a bisphosphonates, we tell the patient, get a dental opinion, do all the dental procedures and give some adequate time before we proceed with bisphosphonates.
Thank you, sir. It's very important that dentists are aware of this. So there are 3 situations where people ask for dental clearance. Okay, one is in case of the cardiac surgery, they want to put some implants. They're going to do a renal transplant. They want to make sure that all infections are treated. One other incidence is here in oncology. Then they are going to be put on treatment like bisphosphonates or long-term immunotherapy or issues with chemotherapy. The dental sepsis. If there is any focus of dental sepsis that is not addressed at that point of time, we will pay a huge price later. It's very important that patients come to you at that point of time, referred by an oncologist to you, spend time with these patients because your work really matters. Now, going on to this patient, without much ado, next biopsy was done, squamous cell carcinoma grade 2. Direct laryngoscopy and pharyngooscopy is always done for any patient with a smoker or a tobacco chewer because you know that the entire upper aerodigestive tract is exposed to the same carcinogens. So it's important that the entire upper aerodigestive tract is imaged or endoscope. We have a lot of options for these patients to do ultrasound neck, CT neck, MRI neck and PET-CT scan. Do not want to take much of time. In this patient, the preferred modality will be an MRI, and that is what we did. So MRI was done. MRI revealed a 3 centimeter lesion in the left lateral border of tongue without any significant nodes. Now, these are the treatment philosophy goals that we have. We have to give cure to the patient, yet achieve a very good cosmesis, and the cosmesis is important as much as the functional. So, without compromising the function and cosmesis, yet you have to give cure, that is the idea. So, the primary modality options are usually a single modality treatment. In these sort of patients, it is either surgery or radiation. You should ideally try to avoid combination of both because the morbidity is more. So surgery in this situation will require a wide excision and a neck dissection. We will go on to the details. And adjuvant therapy in the form of radiation, chemoradiation in selective situations, and systemic therapy in situations that we'll discuss in detail a little later. So this is what the same this guidelines that we have in NCCN as well. In a patient with T1 and T2 clinically node negative, resectable primary without much morbidity, we will do. For this patient, what have we done? We have done a wide excision with an extended supraomoid dissection. So the patient was planned for a wide excision and a left extended supraorbital neck dissection. So supraomoid neck dissection is extended for tongue tumors so that we cover the level 4 nodes, that is the lower jugular nodes as well, because they can have some skip lesions. Now this is the histopathology. 2 centimeter, 2.3 centimeter lesion, squamous cell carcinoma, grade 3. Dissected margins are free. The tumor depth of infiltration is 11 mm. So it's a LBSA, PNI were negative. Worst part of invasion was 4. So it's a very aggressive tumor that we are talking about. T3, and the node was 1 out of 23 nodes in this case was positive. Size of the node was 8 mm. There was no perinodal spread. It's a level 2 node. We have done only an extended supraorbital neck dissection. Harish, patient comes to you next.
Like what you told, to start it was a stage cancer. It was a T2 clinically, but post surgery becomes stage 3. It became T3 at 1.
Very important, because depth of infiltration, no matter what you do, investigations you do, nothing like the pathologist seeing it in the microscope. MRI also clinically T2, MRI also says T2, but final report is T3. This is a quite common scenario. You may not see any significant nodes even on a PET-CT, but final histopathology one not very positive.
So this patient will definitely require adjuvant therapy. So as there was no other risk factors like ENI, IEC or margin plus 2, these patients will require post-op